if you could start off by just explaining who you are, your medical specialty, and where you are based.
No problem. My name's Patrick Byrne, and I work as both a consultant physician and a general practitioner in Belford Hospital in Fort William. So my medical specialty is general internal medicine, and it's a slightly odd combination. I started out life as a general practitioner and was doing that in rural Cambridgeshire for about 6 or 8 years before I moved up to Scotland in 2009. And I did a bit of additional training to get myself on the GMC register for specialist registration for internal medicine. So that enables me to hold both roles in practice and appraise and revalidate in both roles.
Thank you very much. So could you describe the hospital or the surgery where you practice, just giving an idea of the sort of staff numbers and the size of the institution?
Sure, yeah. Belford Hospital it's one of 3 rural general hospitals on the mainland of the Scottish Highlands, and there are an additional 3 on the Scottish Islands of Western Isles, Orkney and Shetland. Now, these are hospitals designated by Scottish government that cover and serve populations of about 8,000 or more. And there are actually 7 of those populations served by these 6 hospitals. Our sister hospital in Oban serves 2 populations, both Oban and further south in Campbelltown. So back to Belford Hospital, it's a 34-bed hospital at the foot of Ben Nevis, which, as you'll be aware, is the highest mountain in the United Kingdom. We have an acute medical unit, receiving unit, which is combined medicine and surgery, all comers. And then we have a step-down, a 15-bed step-down ward where we treat patients with longer conditions that may need a bit more time beyond the sort of traditional 72-hour acute presentation. We would also look to repatriate patients from our nearest hospital, Inverness. Orthopedics is a huge part of our presentations and indeed repatriations, but we would also repatriate them from Glasgow, Aberdeen, Edinburgh, and indeed further afield, and in some cases internationally. We have a 2-bedded high dependency unit, and then we have a very small accident emergency department with 5 bays. We don't have separate specialists in accident and emergency medicine, so those presentations would be seen by the consultant physician or surgeon, or sometimes both with the assistance of the consultant anaesthetist. And for our size, we see about 14,000 A&E presentations every year, of which almost 2,000 will be children.
Thank you. So before we move on, there may be people watching this who aren't familiar with Fort William. So I wondered if you could just describe what is the place, outside of the medical sphere, what is it like there?
So Fort William, it's in a region on the west coast of Scotland, a very, very beautiful region, as many of the locations are on the west coast of Scotland. It bills itself as the outdoor capital of the United Kingdom. So there's pretty much every sport you can probably think of. There is somebody who will be able to help you do it, set it up, whatever. The mountains are a huge draw, particularly that lump of granite at the back called Ben Nevis. And at any one time, at any hour of the day, 365, there's an average of 1,000 people climbing that hill, coming up or going down. The population in Fort William is about 5,000 to 6,000 people, but as you move outside, and the region I work in, or the hospital serves, is called Lochaber, that is about 22,500 people in the last census, but that doesn't include migrant workers, so we'd have a good many people coming in with temporary or seasonal work from the rest of Europe, and these would be servicing the hotels, the bed and breakfast industries, and many others. There's also labour, construction, farming. In terms of agriculture, it's the timber, or the forestry is the word I'm looking for, is a huge industry. And then there are very, very vast estates over quite thinly or sparsely populated land, and some of wealthy landowners own these, but of course these need managing by a team of people dedicated to do that. The big industries in the town are the aluminium smelter, which is probably the town's largest employer, and the hospital, or maybe the fish farm industry, would be the second largest employer. So our hospital has perhaps all told about 300 people employed, but in various different part and full-time capacities across all the disciplines that are necessary for a hospital, both clinical and indeed non-clinical, like housekeeping, portering, and so on.
Thank you. So following on from that, I wondered if you could describe a little bit about your usual work routine. And I know the word usual doesn't always work because it's not usual, but I'm
Yeah.
just wondering, what is your commute like? What are your working hours? The sort of numbers of patients that you see.
So before I moved, as I said, I was a GP in rural Cambridgeshire and living just both at one point in Cambridge and later on in Newmarket. And that was a 1 hour commute each way to work and 1 hour back. When I moved to the Scottish Highlands, that commute dropped to 3 minutes if I wanted to drive, or 15 to 20 minutes if I walked into the hospital each day. So that's a huge gain in terms of getting part of your life back. My normal day would start at about 8:30 in the morning or shortly beforehand, but we would start every single day, weekends included, with what we call a combined board round, where physician, surgeon, anaesthetist, both those coming off call or indeed and those coming on call, would meet with the nurse in charge, and then we would have physio, occupational therapy. Until COVID and lockdown came, we had twice, sometimes 3 times a week, input from social work, because Highland is one of the early adopters to an integrated service where adult care is integrated. Both social work used to be part of the council; it's now part of healthcare. And then we would sometimes even have input from one of the local GPs, also including junior doctors, medical students, nursing students, and we would discuss every single patient in the hospital, those who had come in the last 24 hours acutely on call, those who were on the combined assessment unit, both medical and surgical. And then we would look at those on the step-down ward at least twice a week, but certainly any issues that had cropped overnight on these patients. That would take about half an hour because there's, as I said, with 34 beds, it's not that difficult, although you could have some incredibly sick people. And then from that point on, the physicians and the surgeons would do separate ward rounds. The physios would go and see the patients that they knew about. They would have contributed to that board round I described. So what I'm really talking about is a multidisciplinary ward round or multidisciplinary meeting every single day. Yes, at weekends, it is limited to the clinical, the medical, surgical, anesthetic, junior doctor, and nursing. We don't have 24-hour or 7-day-a-week physiotherapy, occupational therapy, sadly. But it means that by the time we leave that room at 9 o'clock in the morning, everybody knows about every patient. So the physicians will see a surgical patient that we've been asked to see and vice versa. And we don't have to have a convoluted system of communication. The staffing is such that our junior doctors are very junior. They are either first, second, or third year out of medical school. So in the United Kingdom, that would be the first 2 years called the foundation program, and then the first year of higher specialist training, often either in surgery or general practice currently. There is no grade that you would traditionally associate with hospital called a registrar between them and the consultant. So they would escalate any problems to the consultant. Now, ideally, they would escalate it to the consultant on call in that discipline, but because we are small, if that consultant is elsewhere, for example, it may be reasonable that they're doing endoscopy, they will find the other physician or the other surgeon and so on. And indeed, in a crisis, they will find the nearest consultant possible. And they are explicitly told that this is what we expect and this is what we ask them to do, that we can stabilize the problem until we can get the relevant specialist or the person who is in charge of that patient. So in a way, the consultants act down into the registrar role, but actually from a training and education point of view, the junior doctors are encouraged to step up into that sort of decision-making, prioritization, recognition of the critically unwell patient and escalating early. And that's something I actually looked into in the last 2-3 years when I was doing a master's in medical education, and I looked at the trainees' perceptions of their placement in this setting. And that was one of the things they valued most, was that they were trusted to make these decisions, knowing that help was really, really quickly available, but that they were trusted with making these decisions and calling the consultant and explaining the problem and why they needed them to come right away. So that would be the working day. We would do our ward rounds. And then the on-call consultant would invariably be free for the rest of the day, ideally be free of all other commitments so they could respond to the on-call. The person coming off on call may have clinics or other commitments, even commitments. So we have a geriatrician part-time who would do domiciliary visits. The surgeons may have endoscopy, outpatient clinics, minor ops lists, and so on. The workload that comes to us can be incredibly variable. I was asked a couple of years ago, I think 2013, to give a talk on that very subject to the Society of Acute Medicine when they had their international meeting in Glasgow. And so when I corresponded with colleagues in our nearest district general hospital in Inverness and in the tertiary centre, Edinburgh, one of our tertiary centres in Edinburgh, we would be at least comparable to the number of cases we would see annually. We'd possibly see slightly more than Inverness would per consultant, but not quite as much as a consultant would in Edinburgh. Now that sounds a little bit odd, but the rationale is that we would work an on-call of 1 in 3. So every third day you are working 24 hours overnight, coming in the next day, working the next day. We work 1 in 4 weekends. And that's from Friday morning 8:30 right the way through to Monday morning 8:30, and you could be up all night if you've got just one sick patient. So the number of on-calls is incredibly onerous. The intensity of an individual on-call may not be so. So for example, the range of patients that we might admit under a physician would be range from 3 patients to maybe 12. And you've no way of predicting that, but it averages out to about 6 or 7, which is why the numbers over that frequency of on-call are comparable to colleagues in larger centres. And of course, because you only have 3 physicians in-house, so at the moment we have me who does general internal medicine, I have a colleague who does gastroenterology, and we had until recently a nephrologist, but we have to depend on each other for that expertise, or indeed we have to have a network where we can pick up the phone and we have a trusted friend at a distant site where we can call upon that expertise that we don't have in-house. So there's I guess I'm describing a very tight network where we have to depend on each other for skills that best serve the patient in front of us.
Thank you. So your answer there probably follows on quite nicely to the next question I was going to ask, which is, what particular skills or attributes do you think are important for a remote and rural physician, maybe more so than for one in an urban environment?
I think it's really interesting, and this is the idea, even just that phrase, remote and rural physician. And I've said this before at other meetings and conferences. What I practice is general internal medicine. It just happens to take place in a remote or a rural setting. If I was to go back and think back to my university days, it's what my tutors and professors would just have called general medicine. Probably the current students in university, it would be the teachers who taught their professors, but that just probably betrays my own age. But I think you have to have an ability to, or an awareness that you are going to see a broad range of general unselected medical presentations. The fact we are a small unit is no barrier to incredibly rare stuff coming in the door. There are times you will not necessarily know what is immediately going on, but you can stabilize the patient. That buys you some time. Thinking very commonly, a sick child is the thing we are most apprehensive about. And it very often will involve all 3 consultants in medicine, surgery, and anesthetics. So you may find that it's a surgical case, maybe it's a trauma. So the anesthetist, surgeon, and we do have some pediatric trained nurses, they are stabilizing the child, but the physician is actually on the phone both to pediatrics and to the retrieval service to mobilize things. And you have to be prepared. None of us have got additional or extra special training in pediatrics. In my case, I have the diploma in child health by virtue of being a general practitioner, but that's to the skill a general practitioner would do in the community. But we do have the ability to recognize a terribly sick child, to stabilize in line with well-published guidelines. We do have an incredibly supportive network from the pediatricians in Inverness, and indeed our referral would be to them, or indeed to Glasgow if it needed intensive care. So it's just having that network and the ability to build that network for yourself, or to realize that you're stepping into a world where these networks are absolutely vital to your ability to deliver the care and to get the patient safely to definitive care if you can't deal with it. From the surgical point of view, and this would really be location dependent, it possibly applies from the physician point of view as well. You almost have to say, well, what are the needs of this population and how best do we deliver for those needs? Now, that might not necessarily be a consultant. It might not even be a doctor. But you have to see how best can we serve the needs of the population within the finite resources that we have. And where a facility such as ours does indeed call for consultant level care, and I alluded to surgery, as I say, we have Ben Nevis and quite a few peaks around here. We've got pretty bad twisty turny roads that people get frustrated on, take chances, and we see a disproportionate number of road trauma coming into us. So we have to be able to stabilize that trauma and then mobilize get the patient to definitive care, be it in Inverness, Glasgow, or elsewhere. So it's from the surgeon, though. Speaking earlier on, if you are going to be located on one of the islands, then it is very likely you may be called upon to do a cesarean section. That's not part of general surgical training. It's a separate discipline in its own right. It's less likely to happen on the mainland. However, the statistics currently for Belford is that about every 5 to 10 years you will get an emergency cesarean section that you did not see coming, simply by presenting at the front door or by some complication arising and the patient, the woman in labour, is unable to get to Inverness, which would be our normal centre. An emergency such as a cord prolapse needs to be operated on there and then. So, and then of course that means that the physician is often called to either assist at the operation or take the baby over and with the midwives make sure it's stable. So there are skill sets that are necessarily discipline dependent and indeed population needs dependent. But it's a matter of asking, well, what are the needs of this particular population and how best do we deliver on them? But going back to your question, I guess from a physician's point of view, it's general medicine that just happens to be practiced in a remote or rural setting.
Thank you very much. So you've touched on this already, but I wanted to ask you about where you'd worked before you came to Fort William. If you could talk a little bit about that, sure. And if there are any contrasts with your experiences in Fort William that you could make.
So I qualified from Dublin, University College Dublin, and then I worked for 2 years in Ireland before moving to the UK and taking up a GP training post, vocational training scheme in Cambridge. And then I completed that and spent the next 5-6 years, in total 10 years, from including training scheme. I spent 10 years in Cambridge and East Anglia working as a GP in various different guises, a locum, as a salaried doctor, and ultimately as a partner for about 4 or 5 years. And that was in rural Fenland, a village called Ramsey. So I guess rurality has been in my bones unwittingly for a significant proportion of time. I spent, as I say, 10 years there, and apart from 6 months in, I think, 2003, where I was a ship's physician to Carnival Cruise Lines in the Gulf of Mexico, I've been a GP there. While I was doing my GP training, I passed the membership of the Royal College of Physicians examination, because I'm the type of person who works to target. So if I have a target such as an examination, I will definitely learn the subject. Whereas if I feel it would be a nice idea to learn something, it's less likely to be successful. So I guess I had a little bit of insight in that regard, but I thought nothing more of it until the opportunity to move to Scotland came up in 2009. And I thought I would move and become a GP in the area. But actually, I was dating a girl who became my wife later on, and she was a surgeon, and she always wanted to do very general surgery, but with a specialist interest. And there are fewer and fewer places you can do that. And these are the rural hospitals in Scotland, but also dotted around the coast of the UK, in Wales, and indeed parts of East Anglia as well. So I moved to Scotland to be with her, but one of the GPs recognised I had the MRCP exam and put me in touch with a colleague I now work with in the hospital, who was the clinical director at the time, Dr. Brian Tregaskis. And he and one of our managers, Jill McVicker, had pitched an idea to the Scottish Government, who at that point were looking for ideas to staff the remote and rural hospitals. The idea being that it's difficult to recruit and retain consultant physicians, surgeons, anaesthetists. So what if we took a GP who had the MRCP and trained them up to the level where they could run an acute on call, but we didn't, the day job happened to be primary care. You could equally do it with a psychiatrist, and the day job happened to be psychiatry. And the rationale behind that was, in these small hospitals and smallish populations, there's probably enough elective work to support 2 full-time consultant physicians, like, for example, gastroenterology, respiratory, but there wouldn't be enough to support 4, but the rota needs 4 to be, humane and at least workable. And so I was kind of the experiment that walked in just at the right time. It was total serendipity, although they say luck or fortune favors the prepared. And I was the case that proved it could be done. You could take a GP and train them to the level of a consultant in general internal medicine, to the standards required or demanded by the GMC for our NHS. And so that's my career path, and how I ended up. I guess it just shows you that you leave med school and you think you will go down one path, but life takes you in funny directions, right enough.
Thank you very much. So, are there any particular medical complaints or accidents, for example, which are more common in an area like Fort William and maybe less common in an urban environment?
Not really. In terms of general medical practice, no, we would still see some of the same common conditions, chest pain, shortness of breath, COPD, diabetic emergencies, gastrointestinal problems, bleeding, neurological emergencies such as stroke, TIA. So we see the gamut of them very, very regularly. They form the bulk of our on-call acute admissions, acute kidney injuries, renal failure. We see probably a greater proportion of elderly people coming in, because the rural locations tend to be a net importer of elderly patients who have already usually got at least 1 or 2 established comorbidities. And we are net exporters of young people, both for work and for education, as they move towards the larger cities. I say all this pre-COVID, but we tend to have a disproportionate number of elderly patients moving to these areas, both actively in terms of people choosing to retire to these locations, family reasons, people moving back to be with family, people moving their parents back to be with them. So we see probably a disproportionate number of elderly people coming in. It adds a certain complexity in terms of care needs to try and rehabilitate and repatriate them back home. It throws a challenge of how can we do sort of anticipatory or indeed preventative medicine. And one of the innovations one of my predecessors set up and I've carried on is a virtual ward that I have with one of the local practices and their attached nursing home, where we try and look at the frail, vulnerable patients who would be at risk of admission, and we just keep them under a little bit more proactive review with the doctor, the district nurse, social care, and then me at the hospital. And the data that we have collected over a couple of years has shown that has reduced the acute admissions for that entire practice by 30% and the readmissions by 50%. Within 30 days, 50% readmission, reduced by 50%. And that's just looking at the vulnerable elderly patients based on a screening tool called SPARA 65, which is Scottish patients at risk of admission and readmission, and the 65 being that age or older, or local knowledge on behalf of GP, nurse, social care, or indeed myself as consultant. And the total we've really looked at any one time over a year is about 13 or so patients. So it's not very, very many patients, but has a significant impact on sort of the practice stability and indeed the patient stability, and enables them to live in their own home with a little bit more support. I view it as an incredibly good investment of my time. It takes about a half an hour every week, maybe an hour phone call, or we now do it by video. We've been doing it for some time, in fact, well before Teams and COVID. We've been doing it for about 10 years by video consultation. an hour of my time looking at 3 or 4 patients or advising or discussing. Sometimes they absolutely need to come in and it's an easy decision. Sometimes we can order a test and expedite it without having to wait. I can tell you that if one of those gets admitted, I'll spend a lot longer than an hour admitting, sorting them out, working out what's going on. So it's innovations like that that we have had. We've had to implement because we don't have the luxury of choice or waiting. We have to do something because we've only got 34 beds to play with, and we do have a elderly population. But specifically from a physician point of view, no, there isn't unusual cases that present, with the exception that you are more likely to get cases that are out with your training and discipline. So mental health, suicide attempts, overdoses, accidental or deliberate poisoning, pediatrics. You may get problems with early pregnancy or late pregnancy. And while we do have midwives and a very supportive team in Inverness is still 70 miles away, and you have to get the patient there safely and stable, and they may be too unstable to transfer.
Thank you. So following on from that, I realize this might be a more surgical side of things and physician side of things, but okay, you mentioned before the sort of local industry in the area, and you also mentioned Ben Nevis very nearby. Yes. Have there been any sort of occupation related accidents or Ben Nevis related accidents? Do those end up with you, or do they those cases tend to be sort of moved to Inverness or elsewhere?
So we don't see too many occupational related accidents, which is a testament, I guess, to the practices in the local industries. We see them, but not as many as we would see accidents from Ben Nevis climbing, tourism, accidents from the road related to the influx of tourism. So you have to remember that our population, as I said, was 22,500, but for about 11 months of the year, it can be up to 60,000 with tourism. Now, 60,000 people is the population of the city of Inverness, and we have it for 11 months of the year, but yet we're funded for 22,500. Thankfully, many of the people who come on, as tourists, and they're very, very well, we welcome them because it's one of the biggest industries. They tend to be very well, healthy, or indeed, if they've got conditions, they look after them very well because they have to if they're going to travel in the first place. But we do see, you can't predict that some of these people will destabilize and need admission. The hills are always there. It's beautiful. I enjoy walking myself. I'm nowhere near fit enough to be part of a mountain rescue team, and seeing the weather that they tend to go up in, I have no interest in going up. It is absolutely heroic work what they do, because that's usually when the accidents happen, is in bad weather or poor weather. We do see a lot of mountain injuries coming into us. It can be as simple as sprains, stumbles, falls. It can be falls of several hundred meters. One of my colleagues, Brian Tregaskis, is on the local mountain rescue team and has been for many, many years. And he's also the medical doctor to Independent Scottish Mountain Rescue, which comprises the busiest teams in Scotland. 80% of all mountain rescue call-outs for the whole of Scotland happen within our region and would feed into our hospital where medical attention is needed. So hypothermia is another common one, both exposure to the cold or indeed immersion in the water, which is very cold up here. We do see a disproportionate number of injuries coming in off the hill. We'd see a disproportionate number of trauma because the road infrastructure is not good. I mentioned the forestry industry, and you can get caught behind a logging truck and get frustrated and want to overtake it. And as I say on that, it's a very twisty but beautiful journey to Inverness up along the shores of Loch Ness, but you cannot overtake unless you're absolutely sure, and unfortunately people take risks, and some pretty horrible accidents do happen, and they would be fed into us once retrieved by the various emergency services.
Thank you. So we've talked a bit about the sort of challenges that you face as a physician. I was interested in the challenges that your patients face. So are there any particular challenges around staying healthy, or, as you mentioned with the roads, getting to the hospital at all in the first place, or continuing treatment?
Yeah, you're absolutely right. You've hit the nail on the head. Access to services is a huge challenge. So our population area is served by 9 general practice surgeries across quite a vast region. Some of the surgeries will have very small patient populations because that's the nature of what's out there. So it could be maybe 400 or 500 people. It could be 900. It could be 1,500. And then the 3 practices based in the towns have larger practice-based populations. But so even a blood test getting to the hospital can take considerable delay. It can be a day or two before the GP might have the result, and they've got to act accordingly. As in, if the test I'm expecting is going to be this bad, is it not more expedient that I send the patient in? But the patient may then be traveling 2 hours to get into the hospital. By the time they arrive and see me, I know that even so, if I've ensured they're stable and I've done the blood test, accepting that I have an access to something that the GP doesn't have, but I now know the patient doesn't need to stay in hospital. And very often I can't then get them home, that sort of 2-hour, 3-hour journey. There's no transport, there's no bus service, so I have to admit them overnight and try and get them home in the morning. So that does put an extra strain on the system. And you often have a dialogue between yourself and the GP as, okay, will this journey or this admission, will it make a difference, or what can we do in the meantime? And they could come up first thing in the morning, and then we could do the same assessment, but there's a greater chance that you will get them home. So it's having that sort of network and that understanding of each other's limitations is one of the key things to effective and successful patient care with minimal disruption. I guess rurality by necessity has been an early adopter of technology. So we are all very familiar now with COVID and using Zoom, Teams, and all the different software systems. But NHS Highland had pioneered, one of our pharmacists had pioneered a system called Attend Anywhere. And it was a video consultation primarily to just ensure that the medications were correct, the patient was using them, or indeed whether they still needed them. And it won some national awards, came to the attention of Scottish Government, and was being rolled out to serve our rural and remote populations in both the Highlands and the Islands. And we'd been doing it for a few months, and then 6 months, maybe a year, and then of course COVID hit, and of course it became the hot topic of the day. So there are significant challenges to the patients accessing care. We've had to try and innovate to overcome these. We haven't overcome them all, not by a long shot. Loneliness is an incredible challenge. I mentioned the elderly population. You will have quite a few elderly people living on their own or living with their other half, both of whom may be frail, and they will be almost existing in like a perfect symbiosis where each is looking after each other, but they're on such a knife edge, and it would take the slightest destabilization to knock one off the perch, and they have to come in or be admitted or something. But of course, you then have a second incredibly vulnerable person that you have to look after too, lest they decondition and destabilize. So there's that fragility almost of the ecosystem of our patients. Many years ago, a GP, I think he was from Wales, Julian Tudor Hart, coined the term the inverse care law, that the people who live furthest from the facility are often the ones who access it the least. And that is certainly exemplified by rurality. Although anecdotally, I have observed when COVID hit, almost the reverse happened, that when we were looking at having to, do stop face-to-face outpatients, we started telephoning people well before, but 2 weeks, 3 weeks before lockdown was announced. We looked at our clinics and said, okay, if this happens, what do we do? So we were telephoning where it could be done to effect a review, or indeed to say, this is the uncertainty that we may be facing. And by and large, most of the answer was, I was just about to phone you myself, doctor, and cancel the appointment or look at some other way. So there was, I guess, rurality was one of the original isolators anyway, and the sort of mentality that people were already preparing themselves for the fact that they may not be able to come to hospital and may have to look at other ways of doing it. And that's across all ages. That is not just specific to young people. All ages were looking at this and looking at other ways of doing it.
Thank you. So,
in terms of,
oh, sorry.
In terms of no, that's all right. In terms of equity of access, this is where the real tyranny of distance becomes apparent. So a patient might present with chest pain to me in Fort William, or indeed any of our rural hospitals, and they may or may not need thrombolysis to try and remove the clot in an ST elevation myocardial infarct, or they don't have many changes on the ECG that would warrant that, but you still need to admit them, and they will need definitive inpatient angiography. Now, our unit is 70 miles away from Inverness, where our cath lab and consultant cardiologists are waiting. But of course, they have a limited and finite resource also. And my patient will be stable, will be pain-free and stable in Fort William, or indeed Oban or Caithness. But a patient may present to the A&E department in Inverness, and they have the same changes on an ECG, and instead of getting the thrombolytic drug, they can be wheeled around to the cath lab and get the definitive therapy. Or indeed, if they've got the non-ST elevation where they would need medical management but definitive inpatient angiography, they're already at the location. They don't have to be transferred to the location. So this is nobody's fault. This is just the reality and the tyranny of distance staring you in the face. So despite the aspiration of the NHS to deliver equity of care irrespective of your location, the reality does often put pointed glaring holes in our ability to do that simply by virtue of geography. If I'm transferring somebody who is unstable and remains in pain for that very condition, so in hours it will always be Inverness, unless they had no capacity at all, but out of hours I would have to look to Glasgow, which is 2 hours away by road or half an hour away by a helicopter. Now, if I can't get the patient out of pain, they need to be in the cath lab immediately or as soon as possible. So the helicopter would be my ideal journey. But of course, it takes about a half an hour to fly up. Then they have to stabilize the patient, transfer them onto their equipment and their machines, get them back into the helicopter, fly them down and wheel them into the cath lab. So you could be looking at an hour and a half, even with the best will in the world. But if I look out the window, 100 days of the year, the helicopter cannot fly because of the wonderful Scottish weather. So you just need that perfect storm or that Swiss cheese where all these holes line up, and your patient is just drawn a really bad deck hand of cards, really.
Thank you very much. So you've touched on COVID already, but I just wanted to ask, this year has been the last 12 months have been quite sort of momentous in terms of COVID, also in terms of Brexit and discussions around the possibility of Scottish independence. And I just wondered if any of those things will have a significant impact on remote and rural medicine, do you think?
Okay, I'd probably try and take them in order. COVID is probably the easiest one to answer, and COVID has certainly had an effect on our hospital, on our bed management, and on our wider community. Ironically, not really from COVID, but the unintended consequences of COVID. So to give you an example, we've had very few patients admitted to Belford Hospital, or indeed transferred onward to Inverness, who have had COVID or indeed who've been incredibly sick because of COVID. We have had some, there's no denying it, we have had death, but not on a scale that would be seen elsewhere in the larger conurbations. Where COVID has had the impact is the isolation and the need for people to either self-isolate, to shield, or to undergo tests and then isolate because of either a positive or equivocal test. This has had knock-on effect on the carers, on the people providing welfare checks, providing meals for our vulnerable elderly people, bringing them to day centres or lunch clubs, and even the social services or the physios or OTs themselves, their ability to deliver care in the community. It doesn't take much. It only sometimes might take one person not to be available for an elderly person not to get their check in the morning, or indeed to be assisted out of bed in the morning or put back into bed in the evening, or for the meal to be provided. And so that person, through no fault of their own, will decondition and maybe lie in bed all day or sit in a chair all day and not get the exercise or stimulus that they need. And we will be left with a situation where they have become so deconditioned that a hospital admission is the only safe alternative. And that's what we've seen a significant proportion of in coronavirus times, is the number of people who, through the fragility of the support services, both the paid for and indeed the voluntary sector, because we have to acknowledge a good many of the families will be providing unpaid care and support for elderly relatives, or it doesn't have to be elderly either. It can be young people, but with pretty chronic conditions that renders them a bit more frail or vulnerable. So that's been the largest impact that we've seen in terms of our admissions to the hospital, and indeed our bed flow, and the difficulties getting people either back home or, if necessary, to long-term care. COVID has also hit very early on. At the start of COVID, the nursing homes were hit particularly badly. Not all of them, but some nursing homes were hit particularly badly, and this was a national phenomenon recognised, and we were no strangers to that. So that also affected our ability to discharge people into the nursing home when they needed long-term care. So, as I said at the start, COVID, it's been the indirect effects of COVID, not the direct effects. Scottish independence and Brexit, I'll be honest with you, I do not think Brexit has had a massive impact on our ability to deliver services, certainly not the way we practice day to day. Much of our supplies and ordering is done centrally across the whole patch of Highlands, and that will be based in Inverness for obvious and good economic reasons. And our pharmacy, for example, will submit orders through to Inverness, and it'll be taken in the totality. Highland as an area, you've got to remember, is the size of Belgium. So it's a very, very vast area. So there has to be some joined up thinking, and we have to centralize some things for economies of scale. But personally, in terms of delivering healthcare, I have not noticed any impact in terms of Brexit. Scottish independence, we had the referendum a couple of years ago and it was defeated. There is talk about another one. I'll be honest, I think it's talk at the moment. I don't think it's on many people's radar. I think, in 2021, as we are now, it's literally the hope that the vaccine will get us through this to a point where we can emerge from lockdown. I know other parts of the countries have struggled in certain areas or communities with vaccine uptake. I've been astonished at the uptake in rurality. People are, you're pushing against an open door of all ages, all groupings. The uptake has been phenomenal.
Thank you very much. So getting close to wrapping up now, but do you feel that remote and rural practitioners have the sort of support and the voice that they need nationally in conversations about healthcare provision?
No, not at all. Many policies are put out about remote and rural healthcare, and when you look at the contributors, you find that there isn't anyone who actually practices or works in a remote or rural setting. There will be exceptions, but the bulk of people putting together these policies have, at best, a scant understanding or experience. There are people who have spent their lives working in some of these areas, and it is reassuring every now and then when a glimmer of hope or somebody comes along that actively seeks to really scratch below the surface and understand it. So there have been some very encouraging papers put out by the Nuffield Trust. One particular commentator, Luella Vaughan, has really gone into incredible depth. Some of her work has been to do with the challenges faced in Cumbria, so the northern part of England, which is just as remote and deprived as Scotland, and indeed parts of Wales or East Anglia would be. But when I read some policies put out, it has no bearing in reality at all. And then you look at the composition of the panel that have been pulled together to do this. Some of my frustrations have been the fact that we know about all these challenges, and we have known about these challenges since the College of Physicians of Edinburgh conducted the survey and the census of the parishes of the Highlands and the Islands in the 1850s. And from that, we know that one of the challenges is that poverty is in itself a marker of deprivation, a marker of disease, a marker of illness. We know that if the doctor comes to look after people in those areas, while you might have a stunning view and a beautiful place to look at, unless you can earn a living, it isn't going to put food on the table. Now, the advent of the NHS has been instrumental in ensuring that people are remunerated for their work, that people can access healthcare free at the point of delivery. But actually, way before the NHS, we have the Highlands and Islands Medical Service, and then we had the Dewar Report in 1912, which were making these exact points and attempting to set up a system where the doctor could be remunerated appropriately for looking after an incredibly deprived population. We know about all these challenges. We know that it's difficult to recruit doctors of all grades, general practice and hospital grade doctors, to these areas. We know that the on-call is onerous. So I mentioned I do a 1 in 3. We know that there's no opportunity for private practice, and for some people that's incredibly important. But there are other people who couldn't care less about private practice, and it's not about earning lots and lots of money. As long as you can afford a reasonable standard of living, there's a very rewarding job to be had. And we know that if you come to an area but your spouse has got no employment, they will get bored very, very quickly. So either they will be leaving you or you will be leaving the area to save your relationship. And we also know that these areas are incredibly isolated, or at least they are perceived to be incredibly isolated, both geographically, socially, and some would say professionally. But I would challenge that. Who is the one who perceives it to be isolated? I certainly don't. With the advent of technology and the ability to attend some of the continuing professional development functions that both the Royal College of Physicians and indeed many of our sister colleges offer, the opportunity to network way before COVID has always existed. Yes, we have international conferences or national conferences where you can go and each referral when you've met the person face to face at one of these events. So I would challenge the concept of isolation and say, well, in whose mind am I really isolated? Am I isolated in the mind of someone who's never come down and worked walked in my shoes and worked the job that I work and see what I have to do to get a patient stabilized and transferred somewhere else? Luella Vaughan, who I mentioned recently, said, I made the point at one of the meetings, I think it was in Inverness or a remote and rural meeting, it's all very easy to fly off to one of the islands and work for a week as a physician or surgeon and just kick the problem down the road for a week and hand it over when you go back. But where you have to live and work in that area and you have to solve that difficult problem, be it one of placement or social issues or others, to enable your patient to get discharged appropriately and safely. When you have to do it yourself, it's a totally different ballgame. I guess a colleague I met from Bronglaze Hospital, he summarized it best when he said, one of the greatest challenges, ironically, that we face is the intellectual dishonesty of our colleagues and peers, where they would actively stand up in a meeting and say something that they know to be patently untrue. I can use the example, well publicized example of a former vascular physician who said at meetings that it's well known that the quality of doctoring deteriorates the further away you get from Edinburgh. Now, that's incredibly arrogant and insulting. It's insulting to our colleagues in the specialist centres in Glasgow, Aberdeen, Dundee, Perth, and so on. But it's incredibly insulting to even the GPs who are working in practices, not too far from the ivory towers, but without the support, without the access to diagnostics that they have. But it's this sort of blinkered arrogance that is probably the worst thing we have. And it's part of human nature, but maybe we, like many things, we need to call that out when we see it.
Thank you. So just as before we wrap up, is there anything else that you'd like to say that you haven't had the opportunity to cover?
I don't know. It's difficult. I hope I wasn't being too controversial there, but it's nothing I haven't said at a conference or at a public meeting before. There's a perception, I guess, that I'm only working in a remote or rural location because I couldn't get a job elsewhere. And that's not true. I've worked in many, many larger centres. I've worked in both primary care and in secondary care. I've trained in larger centres. I choose to come here. I enjoy the job. It's a beautiful location. It happens to have a very interesting, varied, well-paid job. I guess what appeals to me and why I probably started as a general practitioner and I've then drifted into this hybrid role of both consultant and GP is, I guess, the generality of what comes through the door appeals to me greatly. But of course, I need that super specialist in neurology or cardiology or respiratory to be so specialized in their niche, because chances are I will have to phone them about a patient that together we'll manage, whether it's together and the patient stays with me or I transfer them onward. And it's just about having that sort of dialogue and that collegiality and the willingness to try and appreciate the other person's perspective. I've often said that in terms of training or education, the rural hospitals provide one of the greatest groundings you can get in generalism at the start of either a medical or a surgical career, or indeed a career in general practice. And possibly I would add psychiatry, given the mental health issues that do indeed present at our door. There are perhaps 2 points when a placement in a rural location would serve you best. And that is right at the start of your specialist training, when you will see a huge variety and breadth of generalism. And as I alluded to, you will have the ability to bring on and mature your decision making and accelerate it probably far more quickly than your peers in the larger centres. You also would benefit right at the end of your training when you're about to exit and ready to take on a consultant post, because if you can run the on-call service in a small hospital like this when your ITU is 70 miles away, then you are ready to be a consultant in a larger place when the ITU is around the corner. And the added benefit, if we made placements in these hospitals compulsory for every single medical graduate across the United Kingdom, then it would not matter where they ended up or what specialty they ended up. This is done in Australia, where the graduates have to go to a rural placement early on. The advantage is when I pick up the phone to either a GP somewhere in the United Kingdom or a specialist in a larger centre, I don't have to explain what resources I do and don't have, because they will have remembered from their time in one of these locations. And we can skip all of that and we can get straight on to looking after the patient. And surely that is got to be what it's all about. So I often say that, in terms of career and succession planning, we only need a physician every 10 years if we're doing it right. Now, there's about 7,000 graduates finish med school every year in the UK. And you're telling me that of 70,000 graduates over 10 years, there isn't one who might want to come? Well, I find that really, really hard to believe. And 99% do not need to stay here and do not need to work in a rural location, but all will have benefited from coming here and training here and experiencing it. And I think overall patient care will have benefited, and the NHS as a whole probably might be a more cohesive, joined up unit.